So thank you everybody for joining. Lovely to see you all. We are delighted to introduce Jack Murphy for our inaugural Toolbox learning session of the year. Many of you already know Jack. However, for those who do not, Jack is our billing team leader and oversees one of the organisation's most critical operational functions. Billing sits at the core of our business operations, supporting the financial, compliance, and administrative frameworks that underpin our broader model of care. Jack plays a key role in ensuring these systems operate effectively, efficiently, and seamlessly across the organisation. This session will provide a valuable foundational insight for teams across the organisation, helping build greater understanding of how our billing model operates, why it matters, and the role it plays in supporting compliance, resident experience, and the sustainability of our broader care model. I'll hand it over to Jack. Thank you.
Thanks, Amy. Welcome, everyone. Thanks for joining in online. It's nice to see everyone, and thanks for coming to the in-person session, guys. As Amy's just sort of alluded to, I'm going to be talking about the billing team, kind of what we do in our day-to-day, what our cycles are. We have a major focus on compliance that I wanted to touch on in this meeting. And then to finish up, just talk about our care model and the cost model and how everything's sort of funded. Just because we've sort of got limited time to go through everything, I'm hoping to answer a lot of questions throughout my presentation, with what I'm going to go through. So if we could hold questions to the end, and hopefully I would have answered most of them, but more than happy to sort of tee something up afterwards if anyone's got some burning questions. So to start off, we're going to go through our billing cycle. So my team has a pretty sort of strict cycle that we stick to. We input codes daily, and that's a manual task that we do. It's about 900 codes a day from all of our different doctors' hubs. So we've got GPs, nurse practitioners, geriatricians, and general physicians. And we do that sort of Monday through Friday, billing one day behind live. So we're about as close to live as we can be. Twice a week, we'll throw all of our consults that we've started billing into a bi-weekly file, and we send that off to be processed on a Tuesday and a Friday. As you can see on the bottom bit of that slide there, we have a full weekly coverage in these two file splits. So Thursday to Sunday is on the Tuesday, and Monday to Wednesday is on the Friday. And that sort of covers our full week of billing. We split that by private billing, DVA, and bulk billing. Those are our three sort of main resident statuses. 83% roughly get private billed. About 12% get bulk billed, and the remainder go into that DVA or self-funded world. We also have a backlog that we sort of, and you might have heard the backlog get thrown around, but I'll go into that on the next slide. Sorry, can we just jump back? Yeah. Once we send it off to Medicare, our third-party team at MedBill process all these consults, and that's when the resident receives their rebate. This is for the private billing, that is. They receive the rebate, which we will then we'll grab that from the direct debiting process. So that's kind of our weekly process. We daily input, we put it in a bi-weekly file. It gets processed usually about 24 hours after we send it, and then we'll direct debit that the following week. So we're sort of, g'day James. We run at about 11 days post, on average, a consult to direct debit. And since we've started doing the bi-weekly billing, that's halved it. So we used to be about 22 days consult to direct debit, and that's something we're quite proud of now that we've halved our debtor days to about 11. So if we can go next slide now. The backlog is something that I think gets thrown around every now and then and can cause a bit of confusion. So I'm keen to touch on it in this slide. So the backlog is where residents that haven't yet signed the fee support form, they might have had a bank failure recently. basically we want to try and private bill every resident that we can. So we pop them in this thing called the backlog, where we just hold on to the consults for at maximum 3 months, as it shows at the bottom there. We continue to provide care to these residents whilst we're waiting for bank transactions to clear up, or for the fee support form to come in. The care will continue throughout that time. However, once everything gets cleared up with the fee support form or the banking failures, we'll start taking consults out 5 at a time, to reduce bill shock, because often we can get residents that get 20 to 30 consults built up in the 3 month period, and if we were to take all 30 out at once, it would be quite an immense bill. So we do 5 at a time to try and some of that bill shock. And as I said, if a consult remains in this backlog for 3 months or longer, we just bulk bill it. That's sort of what we've decided on over a bit of trial and error. 3 months is kind of the length of time we want to go before we sort of go, okay, this resident might not be applicable for private billing. So yeah, that's sort of how our backlog runs. I'll just make sure I ticked everything off that I wanted to say there. Yes, cool. We can move on to the next one. Now, this is something I'm quite proud of my team for putting a lot of focus on. As I alluded to at the start, compliance is something that we care a lot about in the billing. We know that at every stage of our process, if we make a slip up, it can be quite a big problem to fix. So we have built this little framework, which we call the 4Rs. And that's basically, we want to make sure we're always billing the right consult and the right code. We're always making sure we're linking the right patient to that consult and making sure their data is all correct in terms of their Medicare card, date of birth, naming, all of that. As I said, right Medicare, that's sort of, we've had a lot of issues in the past with Medicare that we've learnt from. So we make a big effort to ensure the Medicare is always correct, and then right bank account at the end of the process. So these are really important for us, particularly for things with like our nurse billing. It's heavily scrutinized by Medicare just because of how much nurse billing, which is this 10983 code. We actually billed in the financial year 2024 to 25, we billed 89% of Australia-wide nurse billing codes, Access Telehealth did. So as you can imagine, it's heavily scrutinized by Medicare, and therefore we take a lot of effort and pride in making sure it's correctly done. We speak with the practice management team to make sure we're flagging if GPs are overseas, and we check it 3 or 4 times before it gets sent to Medicare, just to be sure we're absolutely billing it correctly. As I said, with the right patient, we use an ID we used to use just naming names, first names, last names, but we've switched to a Helix ID to take out all the problems that can come with duplicate names. And that's the same with Medicare. We use that same ID to eliminate any incorrect Medicares lining up with patient names and things like that. The direct debit file is something that, probably has the highest consequence if we get wrong. If we take money from the wrong bank account, we're going to get in a lot of trouble there. So we, as I said before, put a lot of scrutiny and effort into making sure we're billing the right patient for the right consults. Next slide. So I'm going to move now to the FSP form and our zero out of pocket for residents sort of cost model that we have. I think this is probably the talking point that everyone was most excited for. We have a lot of questions that come through about the FSP form, and it's understandable. It's quite a unique model. I'd say we're one of the only practices and sort of care companies that have a model like this. So yeah, I just want to sort of touch on what it looks like and how we work with it in our billing team. So the FSP form is a consent form that all of our residents sign and allows us to cover the cost of the consult up front. The intention is that once we send these consults to Medicare, the resident will get a rebate and we'll reclaim that via a direct debit, which I've kind of alluded to throughout this presentation so far. So yeah, there is a gap in between what we charge and what we claim, and that's covered by Access Telehealth. We absorb that cost. And that's where this zero out of pocket for residents come. They don't pay for the consult, Access does, and then they'll get the rebate which we reclaim, and the gap is also covered by Access. So it's a really good model for our patients. It allows us to provide a really, really important care model, 365 days of care, a full suite of doctors, including GPs, Jerrys, specialists and nurses on site. It's something that I think a lot of us are really proud of, and the FSP model allows us to run this care model and allow us to keep improving, really. So yeah, that's kind of an insight into the FSP and how we work with that. As I said, about 83% of our patients fall under this model. So a large majority of our billing goes under this model. These are three questions that I think those of you out in the field would be pretty tired of hearing. I know when I've sort of visited some homes, these were the first three questions I was asked by clinical managers, by families, and I think, yeah, even some of our doctors and nurses might, share some curiosity when it comes to these questions. So I'm hoping that, we can sort of discuss what these mean and how we can talk to these in terms of the billing. So from my point of view and from my team's point of view, the amount we charge for consults is more than what your average bulk billing clinic would be charging. However, in order to fund our suite of doctors and our care model, and all the behind the scenes work that goes into it, it's a price that we've sort of worked out is actually, one, within Medicare's guidelines, and two, will allow us to keep improving our care. I think that the key talking point that we always go to is within Medicare's guidelines. It's something we've researched quite a bit, and I don't have the stat on this slide, but we've worked out that our prices for probably our most common code, the level B GP code 90035, is about 1.7 times what you see at a bulk billing practice. So whilst we are sort of higher than what you might see at a bulk billing practice, it's not a overly massive amount and allows us to keep providing the care that we do provide. The fee support program, I sort of touched on it in the last slide, but it's the foundation of this whole model. And whilst it can be a little confusing at times, it allows us to continue providing our care. So, as I said, we cover the consult, Medicare rebates it back to the patient, and we recover that via a direct debit. The gap between the charged amount and the rebate amount is absorbed by us, and we never actually receive 100% of the charged amount. And that rebate we get fluctuates based on each resident's individual threshold. So to be applicable for the fee support program, you need a concession card, which is something that we check in all of our fee support forms. And based on where they are in their sort of threshold journey for the year, our rebate amount actually fluctuates. So these are all important talking points that I think we could sort of talk to when we get these questions out in the field. And then we feel like we're being overserviced, is just about talking to the focus we have on preventative care where necessary. We provide preventative care to the healthy patients, usually so that we can continue to keep them healthy. And, once they sort of hit that end of life sort of stage, our data shows that we actually drop back on that and we're just providing the care that's necessary for that patient. Our model also ensures less polypharmacy and ED presentations for our residents too. So when sort of, as I said, the model's so unique and so untried in Australian healthcare. So it's understandable that these questions pop up. But for us, we sort of feel that we're within everything in terms of guidelines, and we're still just trying to provide the best care for our patients. So yeah, I've kind of ripped through that, but three things to take away. We run on a really tight rhythm in the billing team and focus a lot on compliance. And, the cost model and the care model is sort of a major discussion piece, I think, amongst the company. So the more people who can explain it, the better. And as I said at the start, if anyone's got more questions, that I can talk to, I'm more than happy to catch up with anyone to discuss this. This forum was kind of just to be an oversight of what the billing team is and what we do. And I can get into things in a bit more detail if people feel like they would like that. So yeah, thank you for listening to what the billing team does. Hopefully that was helpful. I might pass back to you, Amy.
Perfect. Thank you, Jack.
Thanks, Jack.
Really insightful. Thank you so much for your time. If anybody does have questions, you can post them into the chat. Otherwise, as Jack said, he'll be available after the session at a later point to take any questions. Any questions in the room? No?
I think really good initiative there for the toolbox sessions. So I think the more knowledge we share, that might make things a bit easier for the teams out and about. So good stuff.
Thanks, Brendan. Thanks everybody for attending and participating, and we look forward to seeing you for the next one.
I'll just add, we're going to send out some surveys after this meeting just to get some feedback so we can keep improving on them. So if there are any particular questions that might not have been covered today that you'd like me and Amy or Jack to answer, you can pop them in that as well. Thanks, everyone.
Thank you.
Thank you. Great toolbox. Thank you.
Thank you.
Thanks for your time.
Yeah.